Very much. Thank you very much for the invitation. It's a real honor to be here for you in Turkey. So I made my first slide in Turkish, although I don't speak Turkish, and I will go on further in English. Thank you very much. So what about CYNM in thyroid surgery? How to do it? What are the pitfalls? And what is the future? Why are we doing nerve monitoring? Well, it's obvious. Bilateral vocal cord paralysis is the most dangerous and warranted complication in thyroid surgery. And, on the contrary, unilateral vocal cord paralysis may sometimes be asymptomatic. So, it has been longly described that routine identification of the RLN is a treatment recommendation, and it's actually the gold standard. But transient RLN palsy is still from 0 to 7.1%, and permanent from 0 to 11% according to different literature. So it's an underestimated, and it's a major cause of litigation, but will improve and improve. So there is more and more literature about nerve monitoring, and when you look into the literature in 2013, you will find already 39 hits for intraoperative nerve monitoring in thyroid surgery. We already, with Greg Randolph and Henning Dralle, showed some electrophysiologic recurrent laryngeal nerve monitoring during thyroid and parathyroid surgery. We have published already some international guideline statements. They will be published soon, also same ones for the superior laryngeal nerve. Now, what's about neuromonitoring? It's about nerve identification, how to find your way. It's about nerve mapping, like a sort of GPS. And at the end, is it a gadget or a tool? Well, what do you require? First, like every surgeon does know, a knowledge of anatomy and embryology, like just stated before. But with intraoperative neuromonitoring, you need knowledge of electrophysiology, knowledge of the equipment, knowledge of influencing factors, and knowledge for troubleshooting. Of course, you need the surgical skills and experience, which we all have. According to the electrophysiology, we mind to keep in mind that there is an action potential, there is threshold, and there is some refractory period. And this is very important to know. So I think the six-step procedure is the success procedure. What do you need to do is a pre-op laryngoscopy, check the vagus pre-dissection, further on the RLN during the dissection, after the dissection, check the vagus again after the dissection, and a post-op laryngoscopy. That's what I would recommend if you do intermittent nerve monitoring. What do you need? Well, it's a tube with electrodes, and the electrodes must be positioned between the vocal cords. It's easy to explain, but it's less easy to perform, like you will see in this video. It doesn't pass, unfortunately. Why vagal stimulation? Well, we all know that the recurrent laryngeal nerve is in danger, and that we are used to dissect during the thyroid surgery. Although when you have an injury here and you stimulate distally, it will say closer to the vocal cords, you will still have a signal. On the contrary, when you will stimulate proximally, that will say higher up to the vagal nerve, you won't have any stimulation at all. So that's the reason why we should perform vagal nerve stimulation, because the proximally we stimulate, the more surely we will be that there are no problem with the recurrent laryngeal nerve. If you want to maintain one diapositive and take it home, it's this one. Now the RLN and its branches. We all know it, like it was disposed already this morning and also just before me, you have extralaryngeal branching, but it divides in an anterior and a posterior branch, and we must have taken account both of them. We might not rely on the inferior thyroid artery. You see on the different schemes that the inferior thyroid artery will have different course. You might take extreme care because it can be a nightmare. So the same pictures I showed here, you see here well the non-recurrent laryngeal nerve. I hope this video will pause. It doesn't. What are the mechanisms of nerve injury? Well, there are 6, and it's very important to keep in mind those. The first one is a transection, second is a clamping, the third one is stretching, the fourth is electrothermal injury. And I don't know in Turkey, but in several other countries with using harmonic dissection devices, this is becoming more and more important. And I will show you later on. Ligature entrapment and ischemia. Ischemia could be an event of electrothermal injury, but later on, delayed. So the most important is stretch injury. You have type 1 and a type 2. And the type 1 is caused by direct stress on the nerve by stretching the thyroid on the berry ligament. It's an upward force like this. The second type is caused by pulling down the distal part of the RLN. And then you won't have a disrupted point on the nerve. Now, what are influencing factors on action potential? There is traction, which could have change in amplitude of about 60% and latency differences in 50%, compression and heat. This is an animal model where we looked at the RLN and the vagal nerve. This is the normal biphasic curve. And what you see is when you have a crush injury that you have a decrease in amplitude and the latency will stays normally in the beginning. When you go further on, you will have a loss, complete loss of signal and no biphasic waveform. Now, those are the arguments in favor of neuromonitoring. You have a reliable identification of the RLN, a verification of the functional integrity, and a guidance in difficult situations, let us say in redo surgery. Now I want to shift gears. What's about vagal nerve stimulation? First, it must be safe. You might not have the direct injury of the vagal nerve, you might not create a hematoma. So here you have the jugular vein, the carotid artery, and the vagal nerve who is there. This is where we all know when we are doing lymph node dissections. So the safety of a vagal electrode design is you have different sorts. You have a closed loop electrode like the APS from Medtronic, and the saxophone from Inomet and Dr. Langer. And you have the open electrode like the S shape, the anchor or the U boat, and the V3 electrode. You have flexible ones and rigid ones. And here you see all of them described with the first Dr. Langer electrode, the U-boat, the APS electrode, the flexible or saxophone electrode, here the completely flexible. And what I wanted to share with you is the advantages of doing continuous vagal nerve monitoring. Like you see here, this is the vagal nerve. If you're looking well, there is here a small tissue. It's a non-recurrent laryngeal nerve. And if you go on the right side with the vagal nerve stimulation, you put the electrode around the vagal nerve and you have no signal at all. You might be very cautious to have a non-recurrent laryngeal nerve. So it's a first sign even before you're going to dissect. especially when your vagal nerve electrode is positioned above the branching of the non-recurrent laryngeal nerve. So if I put this electrode below, I would have a normal signal. Now the safety of a probe placement, it must be atraumatic. The lesser the dissection, the better, of course. The lesser the manipulation, the better. And it must be released atraumatic if there is traction. You have two techniques. You have a lateral way of placing it and medial from the strap muscles. This mentioned that you can perform continuous vagal nerve monitoring within a very small incision of about 3 or 4 centimeters diameter. So you don't need to enlarge your incision to perform intraoperative continuous vagal nerve monitoring. Of course, an open loop will be safer than a closed loop. Now here you see the dissection performed is about 1 centimeter in diameter, and it is without any cause to the vagal nerve. Anyway, when we do dissections of the lymph nodes, we completely denudate the fascia around the vagal nerve because we want to have the lymph node removed that are close to the jugular and carotid vein and artery. So this is a presentation of the S-shaped electrode for continuous vagal nerve stimulation. This was a first prototype. This prototype was right now on running. And why we choose this? Because it's very flexible. You can turn it around the vagal nerve, bend it over the carotid artery, and you have signal in a stable way. So we performed a study from 2010 to February 2012, where we put on 80 total thyroidectomies and 20 hemothyroidectomies. So there were incomplete 180 nerves at risks. What we do was measurement of the V1 vagal nerve stimulation, recurrent laryngeal nerve before dissection, after, and the vagal after. So this is what we did according to the guidelines. And it takes about 90 seconds to place the continuous vagal nerve electrode in place. What you get is this on continuous vagal nerve stimulation. You have a whole range of stimulations and you can get to in detail. So here you see the amplitude, the latency time, and it's going on 3 to 4 times a second. So we have a real continuous signal. What are the results on this study? That we had 4 patients with loss of signal, so 2.2% of recurrent palsy temporary, where all were temporary. There was no permanent one. Why? Normally you have this one. You see continuous vagal nerve stimulation with different stimulations, and then you have a loss of signal. This is what you have when you do intermittent signal. You have a signal, you don't have any one. What we're trying to do with vagal nerve stimulation is to see if we can define a decline in the amplitude here, or changes in latency time that would us reward of ongoing small damage to the recurrent laryngeal nerve. And I will come back later to this. So these are the patient characteristics. They were none or almost non-significant. You see that the OR time was a little bit larger in patients with oral and palsy, also the mean weight of thyroid gland, and also the blood loss. What are the limitations of this study? It was a single surgeon, single center study, and only a small number of patients. So I think we need definitely multicentric studies. What are the myths of vagal nerve stimulation? That I1M replaces meticulous dissection and thorough anatomical knowledge. As far as we know, no problems were seen with vagal nerve stimulation on cardiac output or digestive system. This is very important. Why? Because we're stimulating with a very small current, 0.8 to 1 milliamperes, and it's proven in literature that these small amounts of current don't give any damage to the other functions of the vagal nerve. Another myth is that IONM has no added value. It's a little bit like parathyroid surgery. When you're checking to do a minimal invasive surgery, you want to have an echography, an ultrasonography, and also a system EB scan. Why? Because you want to combine anatomical and functional information. Well, it's the same thing with nerve monitoring. You see it, you have the anatomical proof, but you don't know nothing about the functional. And the functional, we only can have information about this with intraoperative nerve monitoring. But what are the pitfalls? You can have technical problems. Most of them are related to the equipment, hard and software. I confer to the guidelines. You can have a dislocation of the endotracheal tube. You must be aware that movement of endotracheal tube, when the anesthesiologist is positioning it, and when you're lifting or pulling the head, they have a range of motion of about 6 centimeters. You can also have fluid, blood, between the electrode, continuous one, and the vagal nerve, which could disturb your signal acquisition. Of course, actually not all influencing parameters of CONM are fully known. And unfortunately, there are tremendous costs for CONM in all cases. And once again, we'll shift gears. I will go to the future. With a study group, we checked for centers which are performing continuous vagal nerve monitoring, which type of loss of signal we have. And we defined a type 1 and a type 2. And the type 1 is a segmental one. This will say that you will have an injury with an anatomical identification of the point of injury at the RLN. So this will say that if you're going to map the RLN distally from the injury, you will have a positive signal on the RLN. Proximally, you won't have. And you won't have stimulation, positive stimulation of the vagal nerve. A type 2 or global loss of signal, there is no anatomical identification. So on the whole length of the RLN, you won't have any positive sign, neither on the vagal nerve. This is very important to understand the mechanisms of loss of signal. So in this study, we had preliminary data. We have 33% of loss of type 2, and most of them, 67% is loss of type 1. So we can actually define the point of disruption accurately. And mostly it is here at the entrance, 50% of cases in the entrance where the laryngeal nerve is going into the larynx. In 20% is the berry ligament, and in 30% it's lower on due to dissecting. Here you have the loss of type 1. Most of the mechanism is traction and coagulation. And this will improve, believe me. Loss of type 2, the same thing, it's traction and then coagulation. So in a complete loss of signal, global, it's nearly almost traction. So in summary, the preliminary poll data show that there is an increased incidence of loss of type 1 versus loss of type 2. The loss of type 1 is caused by traction in half of the cases, with in 50% at the entry point when the nerve is going to the larynx. Loss of type 1 is 60% complete focal cord palsy early postoperative. But it will recover very soon. After 4 months, there are more than 90% recovery of loss of type 2. And no permanent after loss of type 2 lesions. So, are there any questions? I will be great to answer them. Thank you very much.